Okay. Good evening, everyone. Respected President Sam, Dr. Avinash Bhosle, sir, other office bearers SAMs, then SAM's advisory, all national GCs, then today's invited chairperson, the stalwarts in the field of pediatric anesthesiology, Dr. Snehalata Taigude, madam. She is a consultant pediatric anesthesiologist from Bridge Candy Hospital, Mumbai, and Dr. Pradnya Sawant, a consultant anesthesiologist and the chief of Wadia Children Hospital, Mumbai. Then today's invited faculties, Dr. Poonam Motiani. She is from Noida, that is a postgraduate institute of childcare. Then Dr. Priyanka Karni. She is from MMR Children Hospital, Thane. Dr. Vinit Bedekar. He is from BJ Wadia Hospital, Mumbai. And Dr. Raylene Dias from KEM, Mumbai. So, I welcome you in the SAMS curriculum, that is, child is not a small adult. We will start the program with a small prayer. Now I request our President, Dr. Avinash Bhosle, sir, to deliver his welcome address.
Yes, good evening, everyone. I welcome you for this today's webinar on behalf of SAMS. Children are not the miniature adults, or they are not small adults. Anesthesiologists face multiple challenges while anesthetizing the pediatric patients, right from the preoperative counseling and intravenous access to postoperative care in the wards. Pediatric patients' anatomy, physiology, and pathophysiological manifestations are, these are different from those adults. So we cannot label them as a small adults. In the Indian healthcare system, there is a vast variability in infrastructure, equipment, resources, medications availability, and training programs. Super specialty training in pediatric anesthesia is now evolving. There are now many pediatric anesthesiologists are there. We must take all these factors into consideration while practicing, particularly in rural areas and in the NORA, that is out of operation theater situation. Pediatric regional anesthesia is one of the most valuable components of the modern anesthesia practice. Let us learn about these latest updates on these issues from our speakers and experts on how to enhance the safety and quality of pediatric anesthesia practice while we are doing this pediatric anesthesia practice. So I welcome you all and thank you for joining this webinar. Over to Sheetal.
Thank you, sir. Taking this opportunity, I would like to request you all kindly registered for our annual conference of Society of Anesthesiologists Maharashtra State, SAMSCON, which is going to be held at Pachgani, and it is organized by Satara branch, and it is on 2nd, 3rd and 4th October 2026.
I also take this opportunity to welcome you all. There are already more than 350 registrations there, and those who are not registered, please register for this SAMSCON, first SAMSCON. Actually, it is the first SAMSCON at Pachgani. Thank you.
Thank you, sir. It's my proud privilege and honor to introduce today's MMC observer, Dr. Sanjay Kripalani. He has done the MBBS and MD Anesthesiology and FICM and is a Director of Critical Care Max Healthcare, Nagpur. He is a known critical care specialist and a good clinician and excellent academician. His special interest on poisoning, trauma, tropical fevers, and obstetric critical care. Thank you, sir, and welcome you in this SAMS curriculum. Now I
Welcome,
request
sir.
Dr. Rajesh Tagadpalli sir to introduce our first chairperson, Dr. Pradnya Samant madam. Hello.
Hello, Rajesh. Okay, Sheetal, you.
Okay. It's my proud privilege to introduce the first chairperson, Dr. Padna Shah Sabat madam. She needs no introduction at all, but she is the head of the Department of Pediatric Anesthesia and Pain Management. She is a co-director of Pediatric Anesthesia Fellowship Program, and she's from Vijaywadia Hospital for Children, Parel, Mumbai. She is faculty for dental dissertation at Educational Training Center, then Indian Dental Association, Mumbai, and MGM Dental College and Hospital, Kamote Navi, Mumbai. She has great achievement, that is ex-fellow in pediatric anesthesia. She is a founder and past president of Indian Association of the Pediatric Anesthesiologists. She is a founder member of All India Difficult Airway Association, and she has organized various CMEs workshops on regional and difficult airway, CPR and vascular access pediatric anesthesia, and lecture series for PG. She has been invited speaker for various state, national, and international conferences and also delivered various orations. And she is a recipient of Anesthesia Excellence Award. Then she has published, there are some reference guide from MAM for pediatric anesthesia, and he's a reviewer of paper in Journal of Pediatric Orthopedic. So welcome, madam, to this SAMS curriculum. Now I request Dr. Avinash Bhosle sir to kindly introduce next chairperson, Dr. Snehalata Dayagudani. Hello.
Hello. Yes, it's my privilege to introduce Madam. She is a consultant pediatric anesthesiologist at Bombay. And she is ex-HOD anesthesia in by Vijaywadia Hospital. She is affiliated to Bombay Hospital, Medical Research Center, Bridge Candy Hospital, Sina Hospital, then the Dhanvantri Hospital and Bark Hospital. Her major achievement, she started annual pediatric anesthesia lecture series in 1995 and continued till 2006. And she participated in various CMEs and national conferences. She is founder president of Indian Association of Pediatric Anesthesiology. She was invited faculty for International Assembly for Pediatric Anesthesia, Washington, US, in 2012. She is guest editor, World Clinician Anesthesia, Critical Care, Pain, Pediatric Anesthesia Issue, editor, author of Principles and Practice of Pediatric Anesthesia, published in April. I welcome you, ma'am, for this webinar. Thank you.
Thank you, sir. Now I request Dr. Vikas Karne, sir, to introduce the first faculty, Dr. Poonam Motiani.
Good evening to everyone, and it's my privilege to introduce and welcome Dr. Poonam Motiani, madam. Madam is professor in pediatric anesthesia at Postgraduate Institute of Child Health in Noida. Madam is national executive member of IAPA, February 2025. She is a core member of Neonatal Anesthesia Society. She is an executive member of ISA Noida GBN branch. She initiated pediatric anesthesia services at PGICS in December 2015. She is also a pediatric anesthesia pediatric anesthesia observership at GOSH in London in September 2019. She is a faculty for DM Pediatric Anesthesia exam, IAPA fellowship, FNB Pediatric Anesthesia, and BOTT course at PGICH in Noida. She is Dean Allied and Healthcare at PGICH since October 2024 onwards. Madam is founder editor of the Anesthesia Pulse, which is a quarterly newsletter of ISA Noida GBN branch. She is the organizing chairperson and secretary of IAPA 2024 and has been faculty at many conferences and CMEs. She has 65 publications and more than 140 lectures she has delivered in national and international conferences. And she also has extramural conference grant by ICMR for Rapacon 2027. So welcome to you, madam, and over to Sheetal, madam.
Thank you, sir. Now I request Dr. Sachin Chandokar, sir, to introduce our next speaker, Dr. Priyanka Karnik, ma'am.
Thank you, ma'am. It's my honor to introduce ma'am. Ma'am did MD DNB anesthesia and DM pediatric anesthesia with diploma of European Society of Anesthesiology. She is a consultant at pediatric anesthesia, MMR Children's Hospital, Thane West. She is major achievement executive committee member of IAPA Maharashtra State Chapter, academic committee member of IAPA National, and a certified trainer for pediatric perioperative life support. She is 25 publications in national and international journals with co-authored book chapters in pediatric anesthesia and coexisting diseases and principles and practice of pediatric anesthesia. I welcome you, ma'am, and over to Sheetal, ma'am.
Thank you, Dr. Sachin. Now I request Dr. Shilpa Tivaskar, madam, to introduce our next speaker, Dr. Vineet Bedek.
Thank you, Dr. Sheetal. It's my proud privilege to introduce Dr. Vineet Bedekar. He's a young, dynamic pediatric anesthesiologist. He is MBBS MD Anesthesiology and Fellowship Pediatric Anesthesia. Fellowship in Pediatric Regional Anesthesia also. Sir is a full-timer senior consultant, neonatologist and pediatric anesthesiologist in Department of Pediatric Anesthesia, BJ Wadia Hospital for Children, Parel, Mumbai. Sir has been executive committee member of ISA Mumbai Metro branch. He has done FMB. He has FMB and fellowship teaching faculty for pediatric anesthesia at BJ Wadia Hospital for Children at Parel, Mumbai. Sir has presented numerous papers and posters at various state and national and international conferences, and honors to his accreditation are Best Poster in Consultant category at IAPA Con 2026 held at Nimhans, Bangalore, and sir publications and research projects. Co-authored 9 publications in various journals and 2 textbook chapters in pediatric anesthesiology. We welcome you, sir. Over to you, Dr. Shilpa.
Thank you, Dr. Shilpa. Now I request Dr. Sachin Chandokar, sir, to introduce our next speaker, Dr. Raylene Das.
Thank you, ma'am. It's my privilege to introduce ma'am. Ma'am did MD DNB and DM pediatric anesthesia and neonatal anesthesia. She is an associate professor and in charge of head department of pediatric anesthesia, St. GS Medical College and KM Hospital, Mumbai. She did major achievements in safety anesthetizing neonates and infants and children, IAPA Maharashtra EC member and IJA reviewer. She got KPR Young Anesthesiologist Award 2019 and ISA IJA Best Paper Award in 2018. I welcome you, ma'am. Over to Sheetal, ma'am.
Thank you, Dr. Sachin.
Thank
now
you,
it's
ma'am.
time to start our lectures. So now I request our first speaker, Dr. Poonam Motiani, madam, for dedication.
Thank you very much. Is my screen visible?
Yes, madam.
Thank you. A very good evening, respected chairpersons, distinguished faculty, and my dear colleagues. I would like to begin by sincerely thanking Dr. Pradnya ma'am and Dr. Snelata ma'am for inviting me to speak at this wonderful meeting organized by Society of Anesthesiologists Maharashtra, the SAMS Colloquium. It's a privilege and pleasure to be here. My topic today is PSC in pediatric patients, what's new? Let's explore how recent evidence and technological advances are transforming the way we assess patients and optimize children before taking them up for anesthesia. So, PSC, why does it matter now more than ever? We do realize that the risk landscape has shifted. PSC, earlier on, we know that perioperative respiratory adverse events dominate the morbidity. So preoperative visit is what detects and prevents helps us to detect and prevent perioperative respiratory adverse events. The fasting harm. Uh, Prolonged fasting causes thirst, distress, hypoglycemia. Preoperative visit is the lever that can prevent it. Coming to the neurodevelopmental concerns, fear must be replaced by evidence. PSE is where we can counsel families accurately. And PSE is the earliest point of control for every downstream perioperative decision, be it airway, analgesia, ERAS. So PSE matters more than ever. And the question is not as to, is this child fit for surgery? The question is, how can we make this child safer for surgery? So why is it worth updating PSE? Because the risk is real, concentrated and modifiable. In Apricot study, the incidence of severe critical events was noted to be 5.2%. They were commoner than assumed, with wide variation between centers. Nectarine study subsequently told us that the co-occurrence of hypotension, hypoxemia, anemia raised mortality risk about 20-fold in children. Serious harm, though uncommon, but it concentrates in the very young, the child with the airway or respiratory comorbidity, and the poorly optimized patient. So these studies, the Apricot and Nectarine, remind us that recognizing the risk early allows us to reduce complications before the child reaches the operating room, and that the pre-anesthetic checkup is the single best opportunity to do so. Now, we do know that the neonate is not a small child, and so the PSE should focus on age-specific physiology, prematurity, airway anatomy, the feeding, the OSA, and the behavioral preparation. So recent guidelines from some international bodies have been shaping the way we practice pediatric PSE. So ASA, the American Society of Anesthesiologists, the European Society of Anesthesiology and Intensive Care, the Society for Pediatric Anesthesia, and the American Academy of Pediatrics have transformed fasting, evaluation, and perioperative care. PSE should be able to reflect these evidence-based recommendations into our practice. Now, here is a look at how PSE has evolved over the last 40 years. So PSE has evolved from a stage where we were gatekeepers. There was a binary verdict. Either the patient was fit for surgery or unfit for surgery. There was a single tick box visit. We ordered routine investigations reflexly. Anesthesiologists were almost seen as gatekeepers. This has moved on to personalized optimization, wherein individual risk stratification is done, prehabilitation and modifiable factor workup is done. Now we do take shared decisions, taking the surgeons along with the family and the child with us, and investigations are ordered only when they change the management. The future of PSE would focus on digital, predictive, and family-centered models with the incorporation of artificial intelligence. So the biggest changes, the 5 biggest changes which have happened since the year 2020 are inclusion of liberal fasting guidelines, URI risk stratification, avoiding unnecessary tests, reassuring neurodevelopmental evidence, and point-of-care technology. So routine investigations are no longer justified in healthy children. Investigation should be able to answer a clinical question and change the management. And this has been supported by various guidelines. So the guidelines which were given by the ISAC, the paradigm has now shifted to 631. Solids and formula milk are allowed till about 6 hours prior to surgery. Breast milk has the time has been shortened from 4 hours to 3 hours, and 1 hour for clear fluids. And this liberalization has allowed decreased distress, decreased incidence of ketosis, and better patient management. So now the evidence tells us that rather than reflexly postponing every patient who comes with the upper respiratory tract infection, we must use a structured risk stratification, that is the COLD score, And we must combine this score along with the clinical judgment to decide whether the patient should be taken up for surgery in the present condition or not. Then we come to the evidence update regarding obesity and obstructive sleep apnea. Here, the guidelines tell us screen every child for OSA and for obesity related risks, because these will influence our airway management, the opioid sensitivity, and the postoperative monitoring that needs to be done. So the modern PSE becomes the strategic entry point to personalized perioperative medicine. Coming to the neurodevelopment and anesthesia exposure, what to tell families. So these 3 landmark studies have transformed how we counsel families about anesthesia and the developing pain. The GAS study, the PANDA, and the MAS study. Based on all these studies, the consensus is that a brief single necessary anesthesia exposure in early childhood appears to be safe. One must not delay indicated surgery, but must avoid unnecessary, repeated, or prolonged exposure. And this echoes with the FDA 2016 and the 2017 guide advisory. Now, the technologies which are transforming our practices include the inclusion of point-of-care ultrasound at the bedside. So point-of-care ultrasound is becoming an extension of a clinical examination, improving the airway assessment, the fasting evaluation with the use of gastric ultrasound, and cardiopulmonary assessment using the lung ultrasound and the focused cardiac screen. The other technologies which are influencing the way we do PSE include the inclusion of digital airway assessment with the use of smartphone documentation, ultrasound airway management, measurement, and difficult airway prediction. Also, the introduction of telemedicine PSE clinics, wherein children and parents can be interviewed and the PSE consultation can be done virtually, utilizing telemedicine. So this may help to reduce cancellations and support longitudinal care while complementing but not replacing face-to-face assessment. The other technologies which are making an impact are the use of home monitoring devices, such as the use of wearables like smartwatches, pulse oximeters, sleep monitors, and fitness trackers. They may help to provide additional physiological information about a child's health before surgery. Provided these devices are accurate and reliable, that means they are validated and their use complies with our standards for data privacy, security, and ethical use, these can be incorporated into our pre-anesthetic practice. Now, coming to the special PSE populations which need more attention than others, include the ex-premature infant. Here, how are they different? Here, what is important is the post-conceptual age and not the chronological age drives the risk window. The immature central respiratory control means that post-operative apnea can occur late and after an entirely uneventful anesthetic. This is what makes this group different, that the risk is not in the theater, it is in the hours afterwards. So the planning has to be done in the PSE itself. Additionally, bronchopulmonary dysplasia will add airway reactivity and reduce pulmonary reserve. Reflux will add a aspiration risk. Anemia will compound the apnea risk independently. All these predictors should be taken care of while the patient comes to us in the PSE clinic. On the right side, the points on the right side, every of these points is a decisive factor. So whether whenever patient comes with these problems, whether to defer or to go ahead, whether to monitor or to discharge the patient, whether to take the patient up as a daycare surgery or admit the patient overnight, whether to proceed with a regional anesthetic or general anesthetic, and whether caffeine and hematocrit optimization needs to be done preoperatively. The other population that requires our attention are those children with congenital heart disease. Here again, PSE does not focus only on clearance, but also on optimization. The named lesion may not tell us anything about the current physiology. It may not tell us anything about the shunt direction, the ventricular function, the pulmonary pressures. And a repaired lesion with a good physiology may be lower risk than an unrepaired one with a reassuring name. Repaired does not mean normal. Here again, the question to ask is there a residual shunt? Is there what is the baseline saturation? Is there pulmonary hypertension? What is the ventricular function? Is there an arrhythmia? Is there a device in place? And also one must be able to define as to how recent is the echo and what do we call recent, and what medication the patient is on, whether the patient is on ACE inhibitors, on diuretics, on antiarrhythmics. And this would all change the perioperative plan. One must be able to anticipate and prepare for endocarditis prophylaxis, keeping in mind all the guidelines and the institutional protocol. Also, and also plan for adequate postoperative care. The other PSC population that requires our concern is those with these disorders, which include malignant hyperthermia, drug metabolism variants, the rare disease registries. Here again, a handful of genetic questions will change the entire anesthetic plan, and almost all of them are just history questions and not tests that we can do. Malignant hyperthermia, the PSC deliverable is that there will be a family history. There might be an history of an unexplained perioperative death, unexplained hyperthermia, a relative who reacted badly to an anesthetic. This is the history that is what is going to trigger a trigger-free planning and referral for testing. We do not need a genetic service for this. Similarly, with CYP2 D6, which is the most ultra rapid metabolism convert variant, here these children have a risk with codeine. So one must be able to elicit a proper history before any anesthetic planning needs to be done. So coming to the use of AI in pediatric pre-anesthetic assessment, AI integrates the clinical data to predict the risk by forming certain predictive models, and it helps to support our decision and personalize the care. AI will augment and not replace the pediatric anesthesiologist. Coming to the enhanced recovery, which is part of our protocol always, this begins right in the PAC. So it begins before surgery through a shortened fasting, multimodal analgesia, and family engagement. And a word here about the PSC clinic of 2035. As we look towards 2035, I believe that the PSC clinic will be more predictive, more distributed, and more personalized, and more importantly, more human. AI will help to identify high-risk children early, virtual assessment will become the norm, and precision medicine will enable truly individualized anesthetic plans. But technology should never replace the clinical judgment, and instead it will give us back what PSC has always been about, the child and the family in front of us. So as I conclude, I'd like to leave you with 10 practical take-home points that can be incorporated into our daily practice immediately. First is that embrace the evidence-based fasting. The clear fluids should be allowed up to 1 hour prior to anesthesia. This should become the new standard for most children. Secondly, don't reflexively postpone children with upper respiratory tract infection. Strategize them according to the cold score and decide whether the child should be taken up or postponed for the time being. Then thirdly, order investigations only if they will change the management. Fourthly, reassure about the single anesthetics, about the neurodevelopmental outcome to both the parents as well as to the surgeons. Fifthly, flag repeated exposures of anesthesia under 3 years so that they can be recorded and they can be planned adequately for the next anesthetic, if at all. Fifthly, POCUS should be incorporated into our practice. Sixthly, tele-PSC can be adopted for stable children with low-risk children. Eighthly, individualized beyond the ASA grading. Ninth, document the perioperative plan, and last but not the least, PAC should serve as an optimization strategy and not only as a clearance. So these are some of my references, and thank you for patient hearing. I'll be happy to take questions.
Thank you, ma'am. Very nice deliberation. Over to our chairperson.
Yeah, good evening, everyone. Dr. Daigude here. PAC is one of the pillars of safety for pediatric anesthesia. And as she has mentioned almost everything about the PAC, there is another risk stratification tool that is called NARCO-SS. NARCO means N is for neurological, airway, respiratory, hematological, cardiovascular, and others that includes other things like endocrine and, as she said, hematological, endocrine, hepatorenal, and musculoskeletal or genetic factors. So, and SS stand for severity of surgery or emergency surgery or major surgery or minor surgery, accordingly, the severity of surgery. So this is more relevant to pediatric anesthesia practice. And I think you can just categorize those into mild, moderate, and severe of any systematic disease, and assess the risk. I think she has mentioned everything about every system, and I congratulate her.
Thank you, ma'am.
Thank you, madam. Over to Dr. Padna, madam.
Yeah, hello. Can you hear me?
Yes, ma'am.
Yes, ma'am. Yes.
So actually, yeah, she has done it very nicely in a very precise way. I think very few points I would like to emphasize. One is the preoperative fasting, which is very, very important because I think still in remote places sometimes they do fast a neonate, especially in small children for a longer time, maybe for a 6 hours. So it is not necessary because these guidelines say, as she said, the 3 hours of breast milk, and for older children 1 hour of simple solutions. Nowadays you get good solutions of carb solutions are available, which can be given pre-operatively. Ready-made solutions are available. They are slightly costly, but those who are elite group definitely can have these type of solutions pre-operatively. Second one, what she has emphasized about the investigation, that also I think I must emphasize when the child is posted, all the investigations usually they prescribe. Actually, it is not necessary. When the child is ASA1, minimum investigations are okay, like a blood and urine, and that is sufficient for simple ASA small surgeries. ASA1 or small surgeries, minimal surgeries where do not have blood loss. Major surgeries definitely, and according to the then. And third, I think she has definitely pointed about what you should do about the planning of the PACs, right from the child when you come, their pre-medication, their counseling, telling mother about the neurodevelopment, because nowadays as a pediatric anesthesiologist, when the child is coming repeatedly for the surgery, parents, they do ask, okay, what will happen to our child when the repeated anesthesia is being given. So you have to explain to them what will, nothing will happen. So because we give a minimum and there are better monitoring systems are there. The pain management also we have to, they usually counsel what will happen, how do you give a pain management, that's also very important. I think all these things are PSC. Now initially whenever you used to communicate, nowadays you have to communicate to the child also, you have to introduce yourself because the time has changed. Previously the child would go behind the mother's behind, say okay my mother will talk to you. That's not possible now. So few things are very good. Good, Poonam, you have really
Thank you.
tackled everything. We must know actually in a remote places you must know what cases to be done and what not to do, which cases you can do, especially we are talking about for the general people. As a pediatric anesthesiologist, we always do any institutional very complicated cases. But in periphery, when the resources are not there, how to tackle these children are very important. I think in next lectures also we will see that. Thank you. Good,
Uh,
Poonam.
Thank you.
Thank
yes,
you, ma'am.
madam. I want to ask about the consent of the pediatric patient. Consent of
You
the
want me to
pediatric
answer or
patient.
Poonam?
Pradnya.
Consent
the
of the
parents.
pediatric patients, the parental consent has to be taken, or the legal guardian consent has to be taken if the child is less than 18 years, and if the child is more than 12 years and is able to comprehend, then assent should also be taken for any procedure.
Okay, thank you.
Thank you.
Thank
Yeah,
you,
even
ma'am.
more regarding the consent also, you need to take a whenever the high risk consent are there, you need to explain to the parents. Okay, whenever if the child is going to be get for ventilator or really very high risk patient, that high risk consent also you need to take separately.
Thank you, ma'am.
Actually,
Now,
for a child above 6 years, you can explain the procedure, how you're going to give anesthesia, what is his choice, whether he will accept the injection, and you take the consent from the child itself. And
Yeah.
of course, the parents, you can explain the procedure, anesthesia, as well as surgical procedure, and what can be the outcome, whether the patient is going to have pain afterwards, whether patient is going to, have a little less motor control on the legs after, say, regional blocks and all that. So that also you can explain them beforehand.
thank you, madam.
There is Sheetal, there is a message. You want us to repeat this answer in this chat box also now?
Yes, they can give answer in this chat box.
No, you want us to answer here only, or
Yeah,
we can write it in the chat?
you can
There is one-
answer, madam,
Some you
in
can.
chat box also.
Madam, yeah, you can
Yes,
directly
if
answer
time
in the chat.
permits, we will take the questions and
Question
answer.
Question. Acha, okay. Otherwise, we'll answer in the chat box.
in the chat. Thank
Yeah.
you, ma'am. Now I invite Dr. Priyanka Karnik, madam, for her talk.
Thank you so much. Is my slide visible? I'll just make it slideshow.
Yes, ma'am.
Yeah. So, first of all, I would like to thank my mentors, Dr. Snehalata Thaigude ma'am and Dr. Pradnya Sawant ma'am, and also the dignitaries of Society of Anesthesiology, Maharashtra State, for giving me this wonderful opportunity. And let us now dive deep into the intricacies of pre-medication in pediatric patients. I'm Dr. Priyanka Karnik from MRR Children's Hospital, Thane West. So what we are essentially going to cover in this lecture is what exactly is the problem? Why do we need to give pre-medication? So something about preoperative anxiety, which are the non-drug strategies, that is the non-pharmacological strategies for dealing with it. Then the drug armamentarium, when and who. So what are the indications, contraindications, and the safety aspects of it, and some special situations we are going to be talking about. So my core message is that anxiety is very common in children and in the parents. Anxiety is detrimental if not allayed, but anxiety is very well manageable with the right plan. Why is it so important is because the condition in which you take the child inside the OR is going to define the entire perioperative experience for the parent. The parent is not going to see how well you have managed the patient intraoperatively. But if you take the child away from them in an agitated and crying state, then it will not be a pleasant experience either for the parent, for the child, or for you. And there are some clinical and behavioral outcomes of preoperative anxiety. So it can lead to increased anesthetic and analgesic requirements. Anxious children are more prone to go into emergence delirium. And then there is a higher risk of perioperative complications. For example, if the child wakes up agitated and in distress, then he may pull on the IV line. There can be bleeding from the incision site, and that can lead to your increased PACU as well as hospital stay. Then in behavioral outcomes, what you get is the sleep disturbances, then new onset enuresis or bedwetting, separation anxiety in the future OT experiences, eating problems, and aggression towards authority. So if there is a stressful perioperative experience for the child, then the future medical therapy, again, the child will be very resistant to. So you need to make the entire experience very pleasant for the child. So what are the predictors of preoperative anxiety? Which kind of patients will be more anxious? So younger age, that is particularly children aged 1 to 4 years, that is a toddler age group, is the most anxious, and it is very difficult to actually convince them or counsel them. Then children who are shy, inhibited, they may seem docile, dependent, or withdrawn children, but they have the most anxiety because they don't voice it out to you. Then a brief period available for preoperative preparation. When the parent or the anesthesiologist counsels the child and tells them what is going to happen with them in the preoperative period, or why they are coming to the hospital, that whatever is going to happen in the hospital is going to lessen whatever their problems are, then maybe the child will be more amenable to treatment and more amenable to your pre-medication and taking inside the OR. Then we all know that anxious parents always equates to an anxious child. So the parents also need to be calm. They also need to be counseled well before you take the child in. And in fact, during the preoperative visit itself. Then if there is any previous negative experience of anesthesia or hospitalization, that again is going to impact, the child is going to be very resistant to whatever you try to tell them. And of course, multiple previous hospital admissions, the child is already irritated, agitated. He knows the entire drill. So if you try to sugarcoat the experience, they're not going to really listen to you. Then again, adolescents, they have some baseline anxiety, depression, they have some fearful temperament sometimes, and they have fear of bodily harm or mutilation. But they put on a false facade of bravado, and that crumbles when they see the operating room or when they see the MRI suite. So you may have a calm teenager who tells that I'll come with you, I'll cooperate with you. But once they are shifted inside the operating room, they become very aggressive or uncooperative. So how anxiety it presents across various age groups. So less than 9 months, in fact, infants, they can accept parental surrogates. So less than 6 months, they do not have separation anxiety, and slightly older ones, that is less than 1 year, but more than 6 months, even if you rock them, you soothe them with your voice, then you can easily take them inside the operating room. But the peak anxiety occurs at 1 to 3 years of age because they have poor understanding of surgery. You cannot actually explain to them what is going to happen. But their strength and mobility is rising. So you really need to, you have to restrain them properly. So this is the most high risk group. Now, the 3 to 6 years group, they're more concerned about this bodily harm. They know a little bit, but they don't know most of it. And they respond well to simple explanations. So don't use a lot of medical jargon. Don't make it very complicated. Tell them in a simple way and tell them the truth. And play therapy works very well in them. Then 7 to 12 years, they want explanation and participation, that is active participation. So here you can actually give them a choice of whether they want a mask or whether they want an IV line, and they will tell you what they're comfortable with. And you can explain to them what you're going to do, whether you're going to hold the mask, you're going to ask them to blow the balloon. So all those things you can tell them. And adolescents, again, they are more concerned about bodily harm, about mutilation, but they want active participation. And if you actually tell them what is going to happen and how they can cooperate in making this entire experience pleasant, they will definitely listen. So how to assess anxiety at the preoperative visit? So every pre-anesthetic assessment should explicitly consider the need for pre-medication. When you're talking to the parent, when you're talking to the child, you can easily come to know which child is going to require the most amount of pre-medication, where the non-pharmacological methods will work, and where you will need pharmacological intervention. Ask about any previous pre-medication, whether there was any experience with any other, previous hospital experience or previous operation theater experience where the pre-medication was given and it failed, or there were any adverse events. Then identify the predictive risk factors, which we already discussed in the previous slide, and a careful and individualized risk benefit assessment is required for every child, because some child may have URTI, some may have a difficult airway, some will have an OSA. So based on that, you have to tailor your plan of pre-medication. Now, there is a modified Yale preoperative anxiety scale. It is a validated observational tool to really know what is the level of anxiety of the child, but it is not a clinical tool. It is more of an educational tool. You can use it for your studies to know what is the effect of your pre-medication on the preoperative anxiety. Now, let us come to the non-pharmacological approaches. So if you come to see, there are many of them. So there is preparation and information in the form of leaflets, books, videos, hospital tools. There is play therapy, there is distraction, there is parental presence at induction, there are communication aids and relaxation techniques. All have their own advantages and disadvantages, or some can be very labor intensive. So let us see which ones work and which ones don't. Now, for example, if you can distract a child with the help of a book or a colorful, say, pamphlet, you can show them their favorite animals, then they may, converse with you, and they may not realize what is really happening, that they are being taken inside the operation theater. So here you can see that ma'am is actually talking with the child. She's showing her favorite animal, and she's completely engaged in that, and she's not realizing that she's being wheeled inside the OR. Then you have play therapy. So suppose a child likes a car or a toy, then you can distract the child with the help of that. So here the child is actually saying bye to the mother and coming inside the OR. And as you can see, the anesthesiologist will also now distract the child. He will show him the magic door of the OR, which opens once he presses. So all this fascinates the child. Then we have parental presence of induction. Again, now among all the non-pharmacological methods, this is the most debated one because it has some benefits and it has some drawbacks also. So what happens in parental presence at induction is that you're involving the parents' wishes and you're engaging them in the decision making. There are many parents who ask you, especially in NORA locations, can I be present when you're taking the IV line? Can I be there when you are giving anesthesia to the child? So parental presence induction in these kind of parents, especially if they're calm parents, if they're listening to what you're telling them and they're able to understand that, then it can be a real boon. And it is a part of a broader family-centered preparation approach. But the drawbacks are that it disrupts the operating room routine. It can take a longer time to make the parent aware of what you're going to do, and to make the parent comfortable with this methodology. It puts a stress on the anesthesia provider because a parent is present. So you cannot really forcibly restrain the child. You have to be really careful about what you're saying to your colleagues. So all this can have some legal implications also. And there are various review articles which compare various non-pharmacological methods. So they have shown that parental presence of induction really did not diminish the anxiety. And again, you have an occasional parent who may faint if the child suddenly becomes unconscious. So again, it is going to create two patients for you. So there are various ways of doing parental presence at induction. Now you have to decide whether it is going to be an inhalation induction or you're just going to take an IV line after giving a pre-medication. So what you can do is you can give an oral pre-medication to the child. You can, after the child becomes a little drowsy or sleepy, you can ask the parent to hold the child in such a way that the IV hand is available. Now, before this, you have to really look at the patient's IV lines, which hand has the better ones. You have to apply EMLA cream, or you can use an ethyl chloride spray. And as you can see here, how the child has been positioned, you can just take the IV line without the child seeing the needle. Or if you have a preoperative holding area with a spare anesthesia machine, then you can make the parent hold the child and the mask and start the inhalational agent, and under the inhalational agent itself you can take the IV line. But you avoid drawing the drugs in front of the parents or the child, because that is going to increase their anxiety. Just 1 second. Yeah. I'm not able to see my screen. Just 1 second. Yeah. So avoid drawing drugs in front of parents and child. The child is cuddled by the parent in the cradle position, and you can use scented masks. You can ask the child what kind of scent they like the most, and you can use either ethyl chloride spray or EMLA or Buzzy Bee for IV insertion. I'll just stop sharing and reshare once more.
Okay, okay.
Yeah. Okay. Yeah. Then in this day and age of AI and VR, we have the virtual reality gadgets, which can transport a child into a whole new world. They can be engaged in a virtual reality game, or you can even give them a hospital tour, a virtual reality guided hospital tour. So that can actually distract the child, and then you can take the patient in the operating room. Then there are something called as social story booklets or macathons. So SRCC Children's Hospital has this booklet called as Aryan Needs Surgery. They have designed this with the help of anesthesiologists and surgeons. And here they describe the entire perioperative experience, right from entering the hospital to the nurses coming and taking the vitals, then the anesthesiologist coming and counseling the patient and the parent, and then the entire journey to the OR. So, and there are these macathons or visual aids which are present, which describe each and every step of the hospital stay with the help of pictures or simple words. So all these can be used, of course, the booklet can be used for children who are able to understand properly, and these macathons can be used for children who have learning disabilities or who have autism. They can be made aware of what things to expect when they go to the hospital. Now, if all these non-pharmacological methods are available, then why is or when is sedative pre-medication indicated? So it is mostly used when non-pharmacological techniques alone have failed, which can occur in many times. Then child requiring multiple operative procedures, because as I said, they know everything, they know what is going to happen to them. So they will require a sedative pre-medication. Those with a previous traumatic perioperative experience, and as I said, special needs children like autistic spectrum disorder, or who have learning disabilities or ADHD. They may be combined with non-pharmacological techniques rather than used in isolation. And the need for pre-medication should always be discussed with older children, and there should be alternatives offered to them. Now, what are the goals of a sedative pre-medication? First and foremost is anxiolysis, that is smooth separation from the parents. Then preferably amnesia, so reduced recall of distressing events, vagolysis, decreased anesthetic need, decreased aspiration risk, and anti-emesis and analgesia if at all possible. And what are the contraindications to sedative pre-medication? So there are many, but we have to individualize based on the patient. So anticipated difficult airway, obstructive sleep apnea, increased risk of aspiration. If the child has an acute illness or altered consciousness level, there is an desaturation which has happened recently, upper respiratory tract infection again presents a gray area, or a previous allergic reaction. So all these are relative contraindications. None of them is actually a definitive contraindication to giving a sedative pre-medication. But you need to have certain practical and safety considerations. So always discuss the expected sedative effects with the parents, because you're going to give the sedative pre-medication in the pre-operative area where the parent is present. So if the child suddenly becomes very drowsy or unconscious, then the parent will have a lot of anxiety. They will get panicked. So you have to tell them what is going to happen to the child once you give the pre-medication, and withhold the pre-medication unless there is certainty that surgery will proceed. Even if the surgeon tells you he's operating and he's about to finish, and you can take the patient, you can give the pre-med to the child, but anything can happen in the surgery, any complication can happen, and then your pre-medication which you have given will go waste. So always be certain that the surgery will proceed. Confirm fasting status before giving the dose. Give sedatives only in a safe and observed environment where all your resuscitative equipment is present. So whatever you require, whatever airway equipment is required, your crash cart should be present in that area. Ideally transfer with all your airways and everything present, and monitor the child when you're giving a pre-medication. An appropriately trained staff member, in our case an anesthesiologist, is always there accompanying the sedated child, and have a clear plan for reversal agents, whether you have naloxone, flumazenil if needed. So is the search for an ideal route of pre-medication in children over? No, it is far from over. Now we want our pre-medication agent to be palatable, it should be pleasant, it should have a rapid onset of action, but it should not cause any adverse events, it should not cause vomiting. So there are few which make qualify as an ideal pre-medication. And there are various routes of administration. So we have the oral route, which is the best accepted one. But again, midazolam has a bitter taste. Clonidine has neutral taste. Then you have the buccal, the intranasal. Now we no longer use the rectal route for pre-medication. Intramuscular route is used, but only it is reserved for very uncooperative or combative children. Intravenous, of course, is the fastest and most reliable, but only if a cannula is already there in situ, then we can give. Now, this is a newer route that is a nebulized or the inhaled route of pre-medication, which I'll be discussing later on. It is actually more acceptable to the patient. It is easy to set up and no venipuncture is required. So we'll be seeing which medicines can be given by that. Now, we all must be knowing about this mucosal atomizer device, which is used for intranasal pre-medication. Now, what is the advantage of this device is that, first of all, you don't need to make the child lie down in the parent's lap to give the intranasal pre-medication, because usually if you're giving it only with a syringe, you need the child to lie flat and then you can put it in the nasal cavity. Here you can have the child sitting and this will create a jet of pre-medication which is dispersed inside the nasal cavity. You will have less loss of drug and you will have better absorption. So this can be used with your regular syringes as well. This is just an attachment which you can use with your 1 ml syringe. So it is very important to choose the right pre-medication. So always match the drug to the child's temperament. You ask the child whether they will take oral, or you ask the parent whether the child will have the oral pre-med. If the child is anxious but willing to take oral pre-med, then definitely go ahead with oral, either midazolam, or if the child refuses due to bitter taste, then you can give oral clonidine. But for oral clonidine, you need to at least give the pre-medication 45 minutes prior to your time of induction. If the child refuses oral medication altogether, then you can give either intranasal midazolam or intranasal dexmedetomidine. Intranasal midazolam again stings a lot, so then you may give intranasal dexmedetomidine, but again 45 minutes prior to your time of induction. And you have to consider comorbidities such as OSA, cardiac disease, obesity, etc. You have to choose the right drug for the right patient. So let us come to the pharmacological toolkit now. So first and foremost is midazolam, which is our workhorse agent. We use it day in and day out. It is the most commonly used. So it is familiar, there is quick onset, there is brief duration of action. It is a GABA A receptor agonist and it is water soluble. So usually we use it by the oral route. We give it as 0.5, sometimes even 1 mg per kg can be given, and it produces reliable anxiolysis and antegrade amnesia with minimal respiratory depression. There is no PONV with this, and oral solution has a bitter taste. So it can be masked with either honey flavored drink with 25% dextrose or with paracetamol syrup. But it can fail in up to 20% of the patients, and sometimes it may take a slightly longer time. So usually onset is in 15 to 20 minutes. Sometimes it can take a longer time. So there are various routes by which you can give midazolam, but the most commonest one which we give is oral. That is 0.5 to sometimes even 1 mg per kg. Then intranasal 0.2 to 0.3 mg per kg. It acts also faster, that is within 5 to 10 minutes. Or we can give it IV, that is 0.05 to 0.1 mg per kg can be given in the holding area just before shifting to the OT, because it acts very fast in 2 to 3 minutes. A major problem with midazolam is its propensity to cause paradoxical reaction. Now, the incidence of paradoxical reaction with midazolam, though it is less than 1%, but some psychological problems are seen in more than 9% of the patients. So, it presents as a brief period of sedation followed by aggression, agitation, violent crying, disorientation. Exactly that the things you don't want the parent to see can happen. And we have seen it happen many times. You just give midazolam and the child just starts crying and howling or screaming. So you have to distinguish that the distress has begun after the pre-medication is given. So this is a paradoxical reaction of midazolam. So what you can do now in the best situation is just take the patient as fast as early as possible to the OR, because higher doses are not going to help, and flumazenil reversal you may not be able to give because the child does not have an IV line. though intranasal flumazenil has also been mentioned for paradoxical reaction. Next, we have our alpha-2 adrenoreceptor agonist, that is clonidine and dexmedetomidine. Now, clonidine is widely available. It can be given orally as well as intranasally. Oral dose is 3 to 4 mics per kg. Intranasally is 2 mics per kg. It is better because it is not associated with burning, unlike clonidine, and it does not have a bitter taste also. But it has to be given 45 to 60 minutes prior to taking the child in. So, there is a longer duration or onset of action. And it is superior to midazolam for sedation, PONV, and emergence agitation. And it also has analgesic and anesthetic properties. And we have dexmedetomidine again, which is a highly selective alpha-2 agonist. It also produces sedation resembling natural sleep, and it also causes some analgesia. And its main advantage is that it avoids clinically significant respiratory depression. So there is no amnestic effect, and there is longer time to onset and duration rather than oral midazolam. So again, you have to wait for around 30 to 45 minutes. You can give intranasal route, that is 1 to 2 mics per kg, when the child refuses oral pre-medication. So many a times we have given this prior to MRI. When we have enough time, that is 30 minutes or so, we have given intranasal dexmedetomidine, and sometimes the anesthetic requirement later on decreases a lot. It reduces by half, in fact. Then, as I said, we have nebulized dexmedetomidine. Now, this is a newer route which has come up. So, we can give dexmedetomidine 2.5 to 3 mics per kg via the nebulization route also. So, there are many studies or many papers which have compared nebulized dexmedetomidine with nebulized ketamine and combination of nebulized ketamine and dexmedetomidine. So, nebulized dexmedetomidine can be given 30 minutes prior to the time of surgery, and it works really well, and it has shown to have better acceptability and comparable duration and onset of action. Now, the major differences between midazolam and dexmedetomidine: midazolam is faster in onset, this is slower in onset. Amnesia is present with midazolam. There is pharmacological sedation, and in dexmedetomidine, it resembles natural sleep. Now, respiratory depression is possible with midazolam, but it is very minimal in dexmedetomidine. Then parent separation and mass acceptance is very good with midazolam, but it is also good with dexmedetomidine. There is higher chance of agitation with midazolam. There is reduced incidence. In fact, we use dexmedetomidine for emergence delirium and agitation. But the cardiovascular effects are minimal with midazolam, whether there is increased risk of bradycardia and hypotension with dexmedetomidine. And again, paradoxical reaction risk is more with midazolam and less with dexmedetomidine. Midazolam is again, there are papers which say that midazolam is contraindicated as a pre-medication in patients with URTI. So again, you have to take it with a pinch of salt. Then we have ketamine. So oral ketamine can also be given as a pre-medication. So oral ketamine about 4 to 6 mg per kg. Sometimes higher doses may be required up to 8 mg per kg, but we have seen that when we use a combination of oral midas and ketamine, so you require a lower dose of ketamine as an oral pre-med. So advantage is that it will maintain the upper airway patency and spontaneous ventilation. It is more useful for uncooperative older children who have developmental problems. So there you can use this combination. It really helps in children who have ADHD. Only side effect is that there can be hallucinations and emergence delirium, and also ketamine is known to cause MSS, that is vomiting. So these things have to be taken into consideration. Then ketamine is also given IM, 2 to 4 mg per kg can be given IM also, that is intramuscular, but that is reserved for uncooperative combative patients. Then we have the pediatrician's favorite pre-medication drugs like melatonin and pedicloryl. So pedicloryl is sometimes used for BERA, EEG, and sometimes it works well, and you can do infants and sometimes children less than 6 months, you can do an entire MRI with pedicloryl, but you need to give the right dose, and you still need to monitor the patient even if it is an oral pre-medication. So what to do when the pre-medication has failed before? So you consider whether you had waited for the adequate time for the pre-medication to act, whether the route, the dose was appropriate or not, and whether it was just paradoxical agitation to begin with. If the child has spat out the oral pre-medication, then you can try the intranasal route. And if a low dose has failed, then you can try a synergistic combination. So if in previous hospitalization experience, a single pre-medication has failed, then you can give a combination of benzodiazepine and ketamine, or benzodiazepine and alpha-2 agonist, which we call as a double pre-medication. So you can give clonidine maybe in the ward, oral clonidine, and put monitoring to the child, and then after 30 to 45 minutes you can shift the child to the, or 30 minutes you can shift the child to the OR and give an oral midazolam, which will facilitate or which will fasten your induction. Or you can combine benzodiazepine or alpha agonist with an opioid also. Now let us look at some special situations. Now, if the child has a difficult airway, do you give pre-medication or not? Now, suppose you are not giving pre-medication, then you have a frightened, screaming child with increased secretions where there is difficult to place monitoring and IV lines. Whereas if you give pre-medication, then there is a risk of airway obstruction and desaturation. So then what to do in this case? Now, first of all, for any anticipated difficult airway, the intravenous line has to be secured pre-operatively only. You cannot have a difficult airway where you are anticipated difficult airway where you're securing the intravenous line in the operating room as far as possible, or make it a rule to have an intravenous line already in situ. Pre-medication should be given in the pre-operative area where monitoring, airway and resuscitation equipment is always available. You can give a small dose of midazolam 0.03 to 0.05 mg per kg to just decrease the anxiety and allow separation, and combine it with an anti-sialogogue pre-medication, for example glycopyrrolate, if a fiber optic intubation is planned. Also, you can give ketamine 0.5 to 1 mg per kg. That is also an alternative. It is safe because your airway patency will be maintained. Then you have obstructive sleep apnea, which is commonly seen with obese children, with craniosynostosis, with huge tonsils. So this can cause pre and post-operative airway obstruction and desaturation. So what happens with different agents? Now, what midazolam does, it increases the supraglottic airway resistance. It can cause central apnea. It can blunt the arousal response to hypoxia and hypercarbia. So it has to be given very carefully in graduated doses. Dexmedetomidine is very ideal for this because it decreases the minute ventilation similar to a natural sleep, and it maintains the airway patency and tone. Also, ketamine also helps to maintain the airway patency, but only thing, hypersalivation can be a problem, so you have to combine it with the anti-sialogogue. Then obesity. Now, when you see an obese child, all the problems of obstructive sleep apnea are going to apply to obese children as well, because there can be airway obstruction because of the adipose tissue in the neck. And you have gastroesophageal reflux. So all these problems have to be dealt with. But there are some pharmacodynamic and pharmacokinetic problems also which are associated, because it is altered in these patients. So the drugs which are partially distributed in the fat tissues, for example, dexmedetomidine and clonidine, they need to be given by the adjusted body weight. So the formula for the adjusted body weight is the ideal body weight plus 0.4 into actual weight minus the ideal body weight. So that is the formula for adjusted body weight. Then what the lipophilic drugs, that is benzodiazepines and ketamine, they will have a higher volume of distribution. So the initial dose has to be based on the total body weight, but subsequent doses will need to be according to the ideal body weight. And the hydrophilic drugs like morphine, they need to be dosed by the ideal body weight. So these body scalars have to be calculated, and the drugs have to be given according to that. And when you're talking about the pre-medications, the reversal agents are also very important. So you need to have flumazenil for reversing benzodiazepines. So it competitively antagonizes the benzodiazepine effects. It is very effective for respiratory depression, apnea, or paradoxical agitation caused due to benzodiazepine oversedation. But it can precipitate seizures in patients on long-term benzodiazepines. So you have to check the history first, especially if the child is anti-epileptic, has epilepsy, then there is a propensity to cause seizures. And flumazenil, it is given IV, but there are also reports which talk about intranasal flumazenil in patients who do not have an IV line, and where you are given the midazolam, and it has caused a paradoxical reaction. So in the newer advances, we have remimazolam.
Hello, Dr. Priyanka. It's almost 25
Yeah, this is my
minutes.
last slide now. So this is remimazolam is a newer drug. Of course, it is not available in India right now, but there are reports of using it as a pre-medication. The advantage is that it is an ultra short acting benzodiazepine. Its onset of action is 1 to 3 minutes, but it lasts only for 5 to 20 minutes. So my key takeaways are that you have to deal with preoperative anxiety, deal with it with non-pharmacological or pharmacological methods, combine them together, and we have seen what the drugs which can be used, but individualized for the special situations. And these are few of my references. Thank you. And
Thank you,
sorry for
Dr.
overshooting.
Priyanka.
Sorry.
Excellent deliberation. So over to the chairperson.
Yeah, as she has mentioned, the newer drug, Remimazolam, there is another newer drug, ketamine, S-ketamine, which has a better, post-operative, less delirium, and combination of Dexmed and S-ketamine has become much more popular outside. So hopefully and the dosage can be adjusted according to your protocol, 0.5 to 1 microgram, 1 to 2 microgram Dexmed, and 0.5 to 2 milligram ketamine. So you can, and give it with the atomizer.
And ma'am, S-ketamine is actually shown to cause less, it has less chance of emergence delirium. In fact,
Yeah,
it is
that's what I said.
used to prevent emergence delirium.
Exactly.
S-ketamine.
Yeah. So hopefully we should get that. One thing I would like to say, when the patients are given pre-medication in the preoperative area, and when the patient is shifted from the trolley to the operation table, patients can wake up. So these are the patients between 1 and 6, 7-year-old, which are most uncooperative patients. So sometimes you may have to hold the mask on the trolley itself. And then when the child is asleep, you shift the patient to the operation table. So you wheel the patient in the operation theater on the trolley and induce with the inhalational agent and then shift on the table. Because many patients with just 1 or 2 microgram Dexmed intranasally or 0.5 milligram midazolam orally, more than 50% of the patients will wake up when they are shifted from trolley to the operation table.
Okay, thank you, madam. Dr. Pradnya, ma'am, you want to add something?
Yeah, I just want to add one thing. All these pre-medicates are quite good, and I personally have given a lot of midazolam orally. Because those days previously nothing was available, and still I think in peripheral some people they do practice midazolam given orally and just give some regional block and all the small procedures are with it. Somebody had asked this, is atomizer available? Of course it is, yes, available. So if you take it in a bulk and you can reuse by using autoclave or ETO, you can definitely use. Atomizers are available. I think pre-medications, indications and contraindication already she has said, but where the setup is not good, that pre-op monitoring, I think we have to be just careful. That's all. When we are giving a pre-medication, somebody has to monitor the patient. Okay. Midazolam, I have seen n number of times patients getting hiccups because that is classical of getting midazolam, these things. And ketamine, usually a lot of salivation. So if you can add this anti-sialogam along with that, it works much better, ketamine. Okay. I think in pre-medication is okay. Then pre-medication parental presence, that depends on every hospital, the way hospital theaters are built. I think we will quite a good presentation. I think if somebody wants to ask anything. One more thing. I think in NORA,
we can use at emergency trauma or something like that. In emergency cases.
Yes, emergency. I think in emergency medicine, just recently we had this CME for emergency medicine. So patients who are coming with a trauma, fractures and all, definitely you can give some nasal midazolam or nasal fentanyl in the low doses as a pain relief also. Till the time all these children fractures are not immediately corrected. Usually you put them in a bandage, but for the pain relief in ED you can definitely give this fentanyl, and you can give a oral ketamine also for some time, but then again you need to observe them till they are fully awake.
Okay, thank you.
One or two questions we will take at the end if we have time.
We'll
And one
proceed
more
to
thing, I
next.
just want to ask this pre-medication she has mentioned about the MRI. So those who are double pre-medication is quite a dangerous. Like usually somebody pediatrician they give a pedicloryl, and after that you are called because the patient
Yes.
is not adequately sleeping.
Yes.
Again,
Right,
an
right.
MRI, the scans are going on. So that
Yes.
time you have to really be careful because the pedicloryl and your additional doses and that child you have to monitor. Okay, because you've already given the double dose of both the
Yes.
sedatives. Be
It
careful in
happens
Right.
these
many
patients.
times.
You
Yeah.
can give, but be monitored. You can't send this child as immediately.
Yes.
Thank you, ma'am.
I think
Now
we'll
I
take a
request,
next.
now I
Next.
request Dr. Vineet Bedekar, sir, to kindly proceed for his deliberation.
Hi all, everybody. Is my screen visible?
Yes,
Yes.
it's visible.
Slide
Yeah, all
show
right.
kar.
All right. Hi all, good
Yeah.
evening to all present. I'm grateful to Pradnya ma'am, Daigude ma'am, and the entire dignitaries of SAMS to provide me a wonderful opportunity to rather talk on a very niche topic and the most sought after topic in pediatric anesthesiology, that is pediatric regional anesthesia. I bring greetings from Wadia Children's Hospital, Mumbai, a tertiary care pediatric institute. We at the department have 10 fellowship and 2 F&B seats in pediatric anesthesia, as well as short-term observerships in pediatric regional anesthesia. Well, before I begin, all permissions for videos and photos have been taken, and I do not hold any conflict of interest. Why regional in pediatrics? Does it have a definitive role? From the early 1988 to now, definitely yes. It provides superior analgesia. It has opioid sparing effects. It keeps a patient hemodynamically stable and is a big part of ERAS. It is an integral component rather than merely an adjunct to general anesthesia when it comes to modern pediatric perioperative care. Children are not small adults, as our theme rightly said. There are certain intricacies with respect to anatomy, physiology, and pharmacology, which differentiates pediatric patients than the adults. So whenever you're putting a block or giving a local infiltration in any child, ask yourself these questions. What is the child's age? What is the child's weight? What are the target nerves? What is the maximum local anesthetic dose allowed? And last but not the least, whenever you're putting a block, use age appropriate equipments. Many studies, many randomized control trials have shown that majority of complications are attributed to not having appropriate or age appropriate instruments. I'm sorry, I just lost my screen. Just a second. Yeah, all right. Now this is the first of my 2 important slides of this presentation is this. So these are the anatomical, physiological, and the pharmacological variations that differentiates pediatric patients from adults. So let's see, the pediatric patient's spine ends lower, that is at L3. The bones are cartilaginous and the epidural fat is very loose or fluid filled. What are the implications of these anatomical variations? 1, no punctures above L3. Caudal is a preferred approach. Loss of resistance or POPs could be very misleading. So be very careful while you're doing landmark technique blocks. Ultrasound kind of breaks way here. And there is unexpected rise in the block or higher blocks with the same amount of or the given amount of local anesthetic. When it comes to physiological variations, children have incomplete myelination. Their sympathetic system is immature. What happens is lower concentration of drugs causes and higher level of block or higher motor blockade, and they are less prone to hypotension or bradycardia when dealing with central neuroaxial block. So many complications can be missed here. All right. When it comes to pharmacological variations, they have drugs which are they have less protein binding factors and immature metabolism, which leads to more free drug available, which can also lead to toxicity. These are the commonly used amino-amide drugs which we use in everyday practice. Some pearls here is never calculate the volume first. Always calculate the maximum dose first. Your volume should be based on your maximum dose and never use the full permissible dose here. Always use doses which are lesser than the permissible dose. Of course, an ultrasound can help you reduce drug volume significantly. One question which always puts our knowledge to test is the test dose dilemma. So when young fellows or people who are not adequately trained in pediatric anesthesia come to us, they usually kind of get confused with respect to the test dose. So what is a test dose? A test dose is 0.1 ml per kilogram of 1% lignocaine with 1:2 lakh adrenaline, which is a reliable indicator for an intravascular injection. For example, you have put in an epidural catheter. If you are injecting this solution, and if you see in lead 2 of your ECG, a T wave amplitude which is more than 25%, or a heart rate which is more than 10 beats per minute in an already anesthetized child, or you see something like this on your monitor, what do you have at your hands? We have something called as intravascular injection. So stop injecting, call for help, and follow the last protocol if things go south. Well, based on the provider expertise, anatomical complexities, and potential kind of risk factors, pediatric blocks are divided into basic blocks and advanced blocks. More often than not, the commonly done blocks in everyday practice constitute the basic blocks. Blocks like SAP block, that is serratus anterior, quadratus lumborum, and head and neck blocks form the complex blocks. Well, we have a diverse group of anesthesiologists all over practicing in different infrastructural systems. Many a times ultrasound is not available, which I understand. It is further complicated with inadequate experience using this ultrasound machine, which is again a problem. So in my opinion, one must definitely kind of invest in a peripheral nerve stimulator if you do not have an ultrasound at hand, because all blocks in pediatric patients are usually done under sedation or under general anesthesia. So when you have a peripheral nerve stimulator, you do these things, that is start with a lower current, do not accept a current, a twitch which is less than 0.2, that means you're into the plexus. Calculate your drug and dose even if you're using a peripheral nerve stimulator. Monitor and document. Monitoring and documentation should be on point because it can save you a lot of medical legal hassles. So never, while using a peripheral nerve stimulator, never inject when there is resistance. Do not inject when you get a twitch at a less than 0.2 milliampere current. Inject without aspiration is absolutely a no-no. And overzealous drug volume administration, calling it a volume-based block, is also not a very good thing to do. Wrong interpretation of twitch can land you up in trouble as well. So peripheral nerve stimulator, again, you have to go through the basics of it to understand and use it better. Well, the game changer, ultrasound-guided regional blocks, definitely. Why? Because it visualizes the structures, it visualizes the drug spread in real time, it reduces the local anesthetic doses, decreases number of attempts, decreases chances of toxicity, and hence increases overall safety profile. Hence, ultrasound has not changed what we block, but how safely we block it, which is very important. Well, coming to the kind of a very gist of what you see on USG, so echogenicity is described as black, white, and gray. Whatever is black is fluid. Whatever is different shades of gray is muscle or nerve or fascia. And a bone is usually a hyperechoic rim, that is a dark rim, which doesn't kind of constitute a shadow. All right. I think this is the most commonly or frequently asked questions in chat boxes, usually when it comes to pediatric regional anesthesia. The dosages used in caudal, epidural, and peripheral nerve blocks. As we all know, the green Hermitage rule is for the caudal block. The big chart down there is all about epidurals and continuous epidural infusions. Always remember, only of the FDA-approved drugs in pediatric regional anesthesia as an adjuvant is clonidine in the dose of 1 to 2 microgram per kilogram, and in a few cases, morphine. For peripheral nerve blocks, a volume of 0.3 to 0.5 ml, remembering the allowable mg per kg, is very important. Well, let's honor the timeless classic of pediatric regional anesthesia, also known as the caudal block. Let's see how it evolved from the feeling of the bony landmarks to real-time visualization, or the so-called real-time avatar. So in this small clip, I have tried to demonstrate the landmarks as well as 3 views, which we see on ultrasonography to do a successful caudal block. Let's go. So here I'm starting with the landmark.
Starting exactly tomorrow.
This is the view 1, which is at the sacral cornu, which gives you a pathognomic sign. What is that sign called? It is called the frog eye sign, where the nose represents the ligamentum flavum. sorry, sacrococcygeal ligament. This is a longitudinal view at the sacrum, where you can see lower down at the base of the sacrum, and there are many hyperechoic lines leading into something which is very dark or anechoic. The thing which is dark is the CSF, and the many lines which constitute the ligaments. And this is something called as the incision congruent view or the midline transverse view. Your drug deposition, as seen with the fall of dura at this incision congruent view, tells you how much drug to inject. All right, we'll see further. Now, we stimulated using a PNS and the physiology responded. And what we saw in real time is the USG image of the fall of the dura. So here I'm demonstrating a triple technique, the landmark, the PNS, and the sonography technique, which adds more objectivity to caudal blocks and prevents a lot of complications. So here we go. Skin subcute, sacrococcygeal ligament, drop your angle, go a bit further. Well, is that it? No. Let's scan it. Let's look at a needle, whether it's too much in, too much out. And then we stimulate the phylum terminal at a current which is higher than usual, which is 5 milliampere, to note the anal twitch. Now with the ultrasound, we adjust and readjust a needle. To get a twitch at 5 milliampere current, which would disappear at 2 milliampere current, as we can see. And here we see the classic fall of dura as the drug enters the caudal epidural space. All right. Coming to the upper limb block or the brachial plexus block, as we all know, it provides effective anesthesia and analgesia for postoperative pain relief through continuous catheters or a single shot block of the upper limb. Now, it is universally placed under ultrasound in various approaches. If one has to place it in landmark technique, I would say go for the axillary route. If one doesn't have an ultrasound at hand or not trained in ultrasound, I would suggest to take a PNS needle and put it infraclavicular. And this is how the scanning of the interscalene and the subclavian perivascular, which is also called as supraclavicular block, looks like. Note the ergonomics. The operator stands on the side to be blocked. And here you have the classic traffic light sign of the interscalene. And then we scan the interscalene plexus right up to the time where you see the subclavian pulsations and a bundle of grape appearance later on. As I said, in poor resource settings, one can use a PNS. The finger twitches is what you can see. Here I have demonstrated a dual method of supraclavicular brachial plexus block using a PNS and a sonography. So here you see the real-time visualization of the needle and a stimulus of 1 milliampere.
Meaning that is not seen.
It's not seen, ma'am.
Seen, yeah.
So there you go. There are the twitches which will disappear when the current is lower than 0.5. So once you confirm, you inject the LA and you see the disappearance of the twitches as well as the drug spread in real time. All right. As I said, landmark technique, axillary is preferred because of lesser complications. With the landmark technique, here is how it is done. I would like you to note the hand position, the marking of the axillary artery, and your needle tip entering posterolaterally into the substance of the axilla. After a pop of skin and subcutaneous tissue, there is one more facial pop, and then you can see that needle dancing with the axillary artery. Well, coming to the so now this block is basically a daycare block. Word of caution I would like to throw here is please do not use adrenaline mixed lignocaine, adrenaline mixed local anesthetics in this block. It's a end artery block. So let's see how it is done via landmark guided technique. The 10 o'clock and 2 o'clock position is where the dorsal veins lie below the superficial fascia. So skin subcute followed by a pop more. Aspirate, inject slowly, half to 1 ml of volume suffices. And in the same prick, you can give a ring block dorsally. Make sure your needle doesn't cross the midline and it remains superficial or subcutaneous. And inject as you withdraw. Same thing is done on the other side. So a small volume, around 2 to 3 ml of local anesthetic, does the job for this surgery. It gives excellent post-operative analgesia. Well, coming to abdominal wall blocks, they are regional techniques which provide highly effective somatic anesthesia or pain relief for anterior abdominal wall surgeries, be it umbilical hernias or be it laparoscopic surgeries. Here is a small clip whereby I am performing a landmark guided right classic tap block and a scanning of the rectus and tap followed by a USG guided tap block. So palpate and mark the subcostal margin, the ASIS and the iliac crest, and the mid-axillary line. Use a pop bounce technique. Once you pop the skin subcute, what you get is a bounce. Then you get a pop of the external oblique fascia and an internal oblique fascia. Again, always aspirate, inject slowly. And then sometimes you can see the drug just flowing out. It's like a surrogate confirmation that your drug is not getting seeped into the peritoneal cavity. If you have USG at hand, you can confirm the needle position using the sonography as well. This is a very common technique, the rectus and tap blocks, known to many. This is the rectus sheath plane, followed by the tap plane. So these blocks provide excellent post-operative analgesia. In surgeries, you can add something like a clonidine in a dose of 1 to 2 microgram per kilogram to extend the analgesia. In many surgeries like donor hepatectomies, a continuous catheter can be kept so that you can provide pain relief for more than a couple of days. Well, again, something called as the hernia block, again, a daycare block, which can be done using landmark technique. Here, as we can see, you can palpate the ASIS and the pubis symphysis, divide that line into lateral 1/3 and medial 2/3. Or in pediatric patients, you can just palpate the highest point of ASIS. Like this, and then you can just pop in your needle with 2 pops after the skin subcute pop. And then again, a surrogate confirmation that your backflow of the drug is there when you inject it. All right, the block which has come to life many a times in practice these days is the ESP, or the erector spinae plane block. It is a block where we deposit local anesthetic over the transverse process, between the transverse process and erector spinae muscle. Now, one thing which differentiates adult spine scanning to a pediatric thoracic ESP is the presence of ossification centers or cartilaginous ossifications, which is a marker that you are scanning the right part of the spine. So this is a self-explanatory video. So these are the ossification centers, these ones. And this is how we scan from the lamina right up to the transverse process, followed by the ribs. This is how it looks. So at the level of transverse process, with these ergonomics, you can see a good spread of the drug in real time. A dose of 0.3 to 0.4 ml per kg of ropin usually suffices. Again, you can add some additives like clonidine to prolong the duration of the block. Here's a toughie, $1 million Shakespearean question, I might say. Let's see the all hue and cry around spinal anesthesia, to be or not to be. Let's discuss it in these points. Thecal sac ends lower, as we all know from the previous slide in pediatric patients. So what does it imply? There are more chances of direct nerve injury. In pediatric patients, there is a high turnover of CSF. What that would imply is an unpredictable block height, and it wanes off quickly. So post-operative analgesia here is a concern. There is no clarity on diagnosis and management of PDPH. So complications many a times are missed. Remember, the sympathetic system is immature. Fall in BP, fall in heart rate is not always present. I would say not contraindicated, but definitely guarded. In my opinion, children or neonates who are preterm, with a history of apnea of prematurity, less than 60 weeks post-conceptional age, who have a below umbilicus surgery or a lower limb surgery, one might consider a spinal. I would still go in for a caudal. Threat to life or threat to limb is always an emergency. Inappropriate or no thorough knowledge of pediatric regional anesthesia or pediatric regional anesthesia know-hows might lead to LAST or local anesthetic systemic toxicity, which might be a threat to life, or compartment syndrome, which is a threat to the limb. Let's see local anesthetic systemic toxicity. Well, prevention is better than cure. How do you prevent LAST? You calculate first. You see or visualize whenever possible. You aspirate every 3 to 5 ml and remember to inject slowly. Be incremental in your drug injections and observe the ECG and carefully observe these patients in the post-operative period as well. Do not forget to monitor these patients if you're given a block. Only in the intraoperative period is not sufficient. Also, ideally, I would like to emphasize here that lipid emulsions should be immediately available or at hand. Have you to have any complications? Well, in anesthetized pediatric patients, CVS signs are always before CNS signs. They can occur, as I said, early post-operative period and up to 2 hours post-operatively. Continuous monitoring of SpO2, ECG, and BP is required. Think LAST when unexplained changes in vitals, ECG or consciousness along with ventilation happens. Let's treat LAST. What you do, stop your injection, call for help, oxygenate, give 100% oxygen, please secure the airway. Lipid emulsions, these are the doses. You have to remember the bolus, a background infusion, how much cumulative dose can you give, and the maximum allowable dose, which is 10 ml per kg. And again, if things go south, please resuscitate. Well, compartment syndrome, incidence is approximately 3 per 1 lakh blocks done every year. At-risk procedures include tibial shaft fractures, which are most common, followed by forearm fractures and supracondylar fractures. Now, there's a general dictum or general understanding that always a supracondylar fracture has to go south with compartment syndrome, but it's the tibial fractures which are more common in these. The 3 A's associated with compartment syndrome are anxiety, agitation, and increased analgesic requirement when you have a functional regional block in place, when you have placed a regional catheter or given a long-acting regional anesthetic, and if you have increasing analgesic requirement, suspect ACS. Examine the limb, loosen the cast and dressing with your orthopedic colleague, measure the compartment pressure. Emergency fasciotomies, compartment pressure, again, exam question. If asked in the exam, how do you measure it? There is something called as the Stryker system to measure the compartment pressure. This is the second most important slide of my presentation. Safety first, plan, prepare, perform, and monitor. Always have this safety checklist along with you, pre, intra, and post block. It will take you a long way. Well, whichever technique you use, whatever block you perform, never will you do these things. Never chase a nerve stimulation twitch below 0.2 milliamperes. Never advance an unseen needle on sonography. Please do not use adult local anesthetic concentrations in pediatric patients. Forget cumulative local anesthetic dose. Assume ultrasound prevents LAST. Never do that. Even in ultrasonography guided blocks, there have been cases where LAST is reported. Please do not let your patient just go away. Never not monitor the patient in the PACU. Always have a sister and have a doctor monitor the patient, and do not provide regional anesthesia without lipid emulsion available ideally. What would I always do is I would select the right equipment, the right patient, the right approach, the right technique, the right monitoring, and the right response to avoid complications. Well, beyond every successful block is a child who felt safe. In pediatric anesthesia, success isn't measured by the blocks we perform, but how safe or comfortable our children are. Safe pediatric regional anesthesia is more than just choosing the right block. It is about choosing the right technique, the right vigilance, and putting the child at the center of every decisions. So let's make good friends with them and let's keep them safe because the onus lies on us.
Excellent, Vineet. Is that your last slide?
Fearless, pain-free, and safe. Yes, ma'am.
Yeah. You have covered
with all
it's
gratitude,
beautifully.
passion, and compassion for pediatric anesthesia, I thank you all and for the opportunity provided to present on this platform. Thank you.
Excellent,
You have
Dr.
made it
Vineet.
absolutely indispensable, and regional anesthesia is indispensable and ubiquitous. As
Thank you, ma'am.
It it gives excellent recovery. Patients are happier at the end. One thing I would like to mention, in premature babies, the hernias are very common. So normally we use 0.25% Sensocaine for, good well-built neonate for hernias or circumcision often. But premature babies, you should dilute with normal saline, and below 2 kg, you can go for 0.2%. Below 1 kg, you can go for 0.125%. You just go for, as you know, the nerves are not myelinated. So the lower concentration works very well. And another sign of it, in neonates, when you are given a caudal block and when you have turned the patient supine, you will know immediately the legs are relaxed. So that means it has worked very well. So don't keep the patient on the side. It can become a unilateral block. When you are going to do bilateral hernia, it is better to shift the patient immediately in the supine position. So well done.
Yes, ma'am.
Okay. Thank you, ma'am. Pradnya Sawant, ma'am,
You want me to talk because I have delivered this a number of times regional block lectures, but a few things. One is we have not mentioned about the epidurals. We give lot of epidurals, right, in the caudal epidurals and epidural catheters. So we do put this peripheral catheters and central nervous system catheter as well. And we do give a post-operative infusions. So for the patients who are neonates, infusion you have to give in a lesser concentration. That you must remember. Not the same concentration as adult patients or say in an adolescent. So the concentration you need to reduce. Second thing in, I think most of the things he has covered. I think Dr. Maya Bhalerao, she has asked about the preemptive analgesia. I think even Poonam has mentioned about giving a paracetamol. So in a preemptive analgesia, this is the regional blocks acts very well. Okay. So it is known as like before you give a noxious stimulus, your pain pathways are cut. So that is a preemptive analgesia. So regional blocks are also considered as a preemptive analgesia. I think most of the things I think he has covered it, and I think these are our heart. This thing, pediatric regional anesthesia is our heart, absolutely. Because before that, nothing happens, because we know how important it is in a perioperative or say post-operative pain management. So those who have seen the very comfortable child, they will definitely they will use it. Only thing you is think about the dosing. Dosing is very important in pediatric patients.
Okay, thank you, madam. We will proceed to our last lecture.
Good evening,
Yes,
everybody.
Yes.
Can I start, sir?
Yes, ma'am.
Yes, you have a large topic to cover.
Yeah, the smallest of patients, but I think we can't give them any less attention. The most risky patients, not only for the patient population, but also for the anesthesiologist who is anesthetizing them. So having said that, there are a lot of neonatal surgeries which are being performed today, And one thing that we have to remember that almost all neonatal surgeries are actually emergency surgeries. Because of the age group of the patient and the risks involved, very few surgeries are done electively. So most commonly we are faced with tracheoesophageal fistulas. You can have the abdominal emergencies, omphalocele gastroschisis, the intestinal atresias, malrotations, volvulus, the incarcerated hernias in preemies, necrotizing enterocolitis, again very common in premature babies. So IHPS or pyloric stenosis not really very common in the neonatal age group. They come mostly in the paraneonatal age group above 6 weeks of age. Congenital diaphragmatic hernia not an emergency. They are optimized prior to taking them up. And nowadays there are a lot of other surgeries that are done and a lot of other procedures also where neonates are coming for CT scans and MRIs. So before I start, this is one section of our NICU in KEM, and most of the things that I've learned are from my teachers, Dr. Nandini Dave, and this is Dr. Ruchi Nanavati, the ex-head of neonatology in KEM. Now, the 5 things that Nanavati madam taught me when you're dealing with neonates, which is important, I think, for all of us. The first thing is always wash your hands, cover your hair, put on a gown before touching them. The second thing is use the tips of your fingers, be very gentle. Thirdly, do not use, less handling. So preferably 2 anesthesiologists who are pretty well trained in anesthetizing neonates. That's all that you need. You do not need a herd of people over there in the OT. The fourth thing, sound. So they are very sensitive to loud noises and lights, extremes of lights. So there is a regulation that the sound shouldn't be above 45 decibels in an NICU, and you have to do the same thing in your operation theater when these babies come. And the fifth thing that she would always stress on is warm the child, warm the child, warm the child. So whenever you are transporting them to and fro the NICU to the OT and back, ensure that they are kept warm in as much as possible with whatever resources that you have. So the risk factors in neonatal anesthesia are many, but they are as easy as learning ABC. So the first A is for apnea. So we know that especially preterm infants, they are prone to apnea, and this is more with when they are exposed to anesthesia. Also, the lower the post-conception age, so text says less than 60 weeks. So you remember that even a full-term child who may come to you within the first 6 months of life for a surgery will still be less than 60 weeks post-conception age. So they are at risk for apneas. The next thing is the anatomy of the pediatric airway, especially the neonatal airway. I wouldn't really call it difficult, but it's different. So you need to know the differences to tackle it properly. The airway, then anesthesia itself is a risk factor. You're putting them, as it is, you have life on a precipice, and now you are adding more to that stress by exposing them to surgery and to anesthesia. Analgesia, a lot of people are a little wary about, giving especially IV agents. But remember that neonates are the population where for a very long time we thought that they do not actually feel pain, but we know that that's not true anymore, and we have to take care of giving them good analgesia as well as good anesthesia, because they may be at risk of awareness the same way in which cardiac patients and elderly patients are at risk. The next alphabet is the letter B. So B is for breathing. They may have a type of periodic breathing where they have, they may have some amount of tachypnea, and then followed by they just stop breathing for some time, some pauses, but that may be normal in children or in neonates. Also beware of high FiO2. So now we are in a scenario where we are using the least possible FiO2s that we need for the lowest possible time, because we know of the risk of oxygen toxicity to the developing brain and what it does to the retina and predisposes them to risks of bronchopulmonary dysplasia later on in life. The circulation, so they are now we are in the letter C. They're in a phase of transitional circulation where they have a duct which at any point, any stress, hypothermia, acidosis, raised CO2 levels, sepsis, a lot of other factors which can easily transition them back into the fetal state. So we need to be careful of all those factors, and take care to avoid them, including hypothermia. So pulmonary hypertension is a common problem in neonates, and it is especially more prevalent in children who have congenital diaphragmatic hernias and those conditions where there will be a component of primary pulmonary hypertension where the lung is hypoplastic. So their cardiovascular system is also immature. The sarcomere formation is not complete. The mitochondria are not enough. They need calcium for contraction. So they are very prone to any effects of hypocalcemia. Immediately they go into cardiac, they become unstable. So they have a parasympathetic dominance, and this is right up to 6 months of age. So any stress or any hypoxia, immediately they go into bradycardia, and we need to be careful. Again, the next C is for congenital anomalies. So we need to look for that. Some of them may be syndromic, watch for that. And if they have those comorbidities, then you need to get a further workup done. Most commonly, cardiac defects, you would need to get a 2D done. So the other risk factors are, we come to D. So D is for disability. So they are obviously, because you are exposing the neonatal brain to anesthetic agents, and Poonam ma'am has also said that the 3 main trials have now shown that a single anesthetic only. But these are small neonates. We still do not know, and it's not only the anesthetic agent that you're giving, but a lot of other things that you're causing with your anesthesia and surgery, like it could be hypotension, hypoglycemia. So all those things can predispose them to neurological problems. Next is the drugs. Most of the drugs that are used in neonatal anesthesia are all off-label, and unfortunately.
Hello, ma'am.
Yeah.
There is echo sound. Are you joined with?
Yeah.
Dinesh?
1 second. Let me just. Okay, I hope it's better. I had a device. Sorry, I forgot.
Yeah.
Yeah. Okay. Sorry. So most of the drugs that are used in neonatal anesthesia are actually off-label. Unfortunately, we do not have a lot of trials in the neonatal age group. But let me tell you that off-label use of drugs in neonatology, it is ubiquitous, it is legal, and it is ethical. So do not be afraid of using drugs if you know that it fits that indication. Next, the next is alphabet is for environment. So make sure the temperature is proper and they are warm at all times, especially during transport. And then we come to F. So F is for fluids. We give solutions of 1% dextrose and Ringer's lactate, or you can give Plasma-Lyte solution, but you definitely need to monitor for your G. So G is for glucose. So you monitor for hypoglycemia. Now it is the cutoff is usually 40 for term neonates and 30 for preterm neonates. But remember, even hyperglycemia is a concern in children. So if you give a lot of sugar without monitoring, and if you're going to send them back to the NICU with, there have been instances where sugars have been in 300, 400 range. The problem is that hyperglycemia again is bad for the brain, and it also causes a lot of osmosis. So osmotic diuresis, and they go into complete cardiovascular collapse, and they are very hypovolemic. Then we come to the letter H, which is for hematology and mostly coagulation. So everything is haywire here. You need to supplement them with vitamin K. You may have your INR values, which may be very high, but they are actually normal for that age group. So be aware of all of that. Then the next stage is hypos and hyper. So I've already covered glucose. Then we have hypocalcemia, which is common in this age group. Potassium levels are normally slightly higher in neonates. Sodium also may be haywire. The next hypo is for hypothermia. Temperature and hemoglobin values are much higher in neonates. Then we come to the letter P. There are 3 P's here, that is periventricular or intraventricular hemorrhage. So they have a very narrow range of cerebral autoregulation, just 20 to 40 millimeters of mercury. So if your mean arterial pressure goes below 20 or above 40, they are going to be prone for ischemia. And above 40, they're going to be prone for intraventricular hemorrhages. So that is one of the commonest cause of hydrocephalus in preterm neonates, in NICUs. So you have to be very careful about the blood pressures that you maintain intraoperatively. The next P is for pain. So, like I said, do not make any restraints when giving pain. When giving pain relief, they should be adequately anesthetized. P is for prematurity. So, all their organ systems are immature because of their small size and their young age. So, you need to take into account the metabolism of drugs, which is going to be delayed, and preferably use drugs with faster metabolism, and avoid the longer acting agents in this age group. Then we have S, which is for sepsis and small size. So sepsis is a common problem, especially in preterm babies. And it also depends on the T, which is the type of surgery. So most surgeries are emergency in neonates, and they may be very high risk, involving a lot of fluid shifts and blood losses. And the last alphabet is for vascular access. So you have to so nowadays we use a lot of actually IV access is very easy in the neonatal age group, but that is provided the IVs are not fired. And believe me, NICUs, they manage these IVs so well that if we take a great saphenous, if we cannulate the great sap, they actually leave that, only for PICC lines. And if by chance you do it, they really get very upset. So you have a lot of other veins which are available, and it is relatively easy until it's difficult. And then we have the ultrasound now, or you can go for central venous cannulation. So always remember, when you are intubating neonates, the rule now is to para-oxygenate them. So there are various devices that you can use. So one is the HHFNC, that is the heated humidified nasal cannula. This is the Airvo system which we have. And then you can use the RAMS cannula. This is the interface. You also have the blades with the oxyport. This is the Miller blade, size 0. So here you can continuously insufflate oxygen during intubation. So it should be para-oxygenation by any means. And they say now video laryngoscopy should be your first choice in neonatal intubations. So any video laryngoscope can be used. Monitoring should be very meticulous. So this is the Masimo SET technology. This is the root monitor, but you get quite economical versions of this. It's a very good monitor for neonates because the interface that you attach to their limbs is, it causes least pressure, unlike the other pulse oximeter probes. And you can see here, you get so many values. So you get real-time hemoglobin. You also get the PVI. You can also get the perfusion index. So these are you can also get something called an oxygen reserve index. So this is a very good monitor to use. And we also monitored the cerebral or regional oxygen saturation. So these are the NIRS probes, and this is the inverse cerebral oximeter. So this is important to ensure that you're not causing any neurological damage. And you can also use this on other sites if you want to monitor for renal perfusion, etc. So the access to our babies is limited, and this is like after induction. But what happens after the baby is draped? So this child was taken down to the lower end of the table for a cystoscopy. You have absolutely no access. So you have to ensure that you have long extension tubings. Use arterial extensions, that you do not have to flush too much of fluid boluses. So now that you know your ABCs, next time I'm sure all of you all can anesthetize neonates along with me. So I'm now going to move on to a few of the regular cases that you might get in your practice. So this is a spot diagnosis, and I'm sure it wouldn't take much time to diagnose this. So this is you can see the catheter here, which is coiled in the upper pouch. And this is so this is a case of tracheoesophageal fistula. And here, if you can see, you can see the gastric bubble here. However, over here, gastric bubble is absent. So this is a casus abdomen, and this is a classic case of esophageal atresia. Now we have the gross classification, and the commonest type is the type C, where you have the lower end which communicates, and the upper end of the esophagus is blind. So this is commonly associated with a Vactral anomaly as high as 20%. And V is for vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb. So if they have at least 2 out of these, that qualifies them for Vactral. And now we have something called a Vactral H association also, that is Vactral with hydrocephalus. So all of these anomalies are very common in these babies. And how do we prepare these children? So first, you keep them nil per oral. You establish an IV line, there are copious secretions, so you need to hydrate them well, give them a head-up position because they are prone to aspirate all those secretions. And we put this Replogel tube and you connect it to low continuous intermittent suction. Now, you can get all of these done, but a chest X-ray or something called a babygram, where the entire child gets covered on that film, that is enough, and that will give you a lot of information. This is one neonatal emergency where you have to wait for an echocardiogram because the association with cardiac anomalies is very high. So a renal ultrasound is usually done because, like I told you, in Bacterial, renal is one component. So the chest X-ray or the babygram gives you a lot of information. So first you can see the catheter coiled in the upper pouch. You can, if there are cardiac anomalies, they may be evident. You look for the lung fields to see for any aspiration pneumonitis. You look for vertebral anomalies, so they may have hemivertebrae or absent vertebrae. You look for the gas in the abdomen, whether there is a stomach gas or whether it's a gasless abdomen. So if it's gasless, it's an esophageal atresia where you need to do a staged procedure over there. And you also look for extrathoracic vertebrae. So that is, if there are more than 12 vertebrae here, that's an evidence that it's an indirect evidence of a long gap. So those children may benefit by directly going in for a staged procedure, which is an esophagostomy and a gastrostomy, a complete diversion. So you can, in the babygram, you can also look out and you can make out if there is a horseshoe-shaped kidney or if there are any obvious renal anomalies. You may see the kidney shadow. So intraoperative management, the problem is in intubating these children. Now, what we follow is we do a video laryngoscopic guided intubation, and we do not follow all these things. We do not do a right mainstem and then remove. We just ensure that the bevel is directed anteriorly because the fistula is posterior. So the posterior part of the tube is going to directly occlude the fistula. Now the problem is, if you have fistulas which are very near the carina, and actually there's nothing much that you can do about it. So we used to try these bronchoscopies through the 3.5 endotracheal tube, but it's not that easy to see these fistulas. And the problem is, what are you going to do if it's very close to the carina? So there's only one thing that the surgeons can do, that, as soon as possible, they ligate the fistula, and that will really help to improve your ventilation and your other parameters. So a lot of, there's going to be lung collapse because they're going to retract the lungs. Your tube may get blocked because of secretions, a lot of hypoxia. So all these events, the VQ mismatch in the lateral decubitus position, the retraction of the lungs, the vagal responses, the amount of bradycardias, if there are too many of these events, all that would guide you towards your extubation, whether you should extubate these babies or no. So post-operatively, if all is well, it is desirable to extubate them early and keep them spontaneously breathing. Now, if the surgeon tells you that, there probably is a lot of tension on my anastomosis, those are the babies who you would keep intubated. And in that case, you would keep them intubated for at least 72 hours with the head in a flexed position. You need to ensure that they are nicely sedated, and they're not going to keep moving their head, because that will cause disruption of the anastomosis and an anastomotic leak. So pain management you can do with IV narcotics if they are intubated, and we perform an erector spinae plane block now for all of these procedures, so that helps in early extubation as well. So this is, Vineet has already described this, so I'm going to skip this, and you can see here the drug is, going into the plane between the transverse processes and the ESP muscles. And next, I'm going to move on to congenital diaphragmatic hernia. So this is, again, these babies are very sick from the time they are born, and a lot of them need intubation right at the time of birth. And here you can see a mediastinal shift, and that is what you get. You will get a scaphoid abdomen, and you will get the heart sounds on the right side of the chest, and you will get bowel sounds on the left side. So here you can see the entire intestines have herniated into the left side of the chest, and the stomach, you can see the tube, the Ryle's tube is also in here. So the stomach is also a content of this hernia, and that itself tells you that this is a bad prognostic indicator. So there are a lot of prognostic indicators antenatally. If they are diagnosed very early on, that means that the lung hypoplasia is going to be very severe. So these are the children who are really going to trouble you intraoperatively and postoperatively as well. And postnatally, if the defect is very large, if they have associated cardiac anomalies, if they have chromosomal abnormalities, severe pulmonary hypertension, if their birth weight is low and a small contralateral lung or a bilateral CD8, all of these are poor prognostic indicators. So a lot of syndromes are associated. You look out for Beckwith-Weidman charge, the trisomies, and again, a lot of congenital anomalies like cardiac anomalies are commonest. You can have spina bifida, hydrocephalus also may be associated. So the other conditions which really and truly complicates your management is the bilateral lung hypoplasia, which causes the significant persistent pulmonary hypertension of the newborn, and that causes all the morbidity and mortality. Now, they present, like I said, with respiratory distress, and one thing that you need to look for, of course, the ABG, but a simple thing that you can look for is the difference in the pre and post-ductal saturation. So you can keep one on the right hand and the other on the foot. And if this difference is more than 10, that would guide you that there is significant pulmonary hypertension over here. So these are the babies who need to be optimized. And in our center, we have seen that if we wait for at least 72 hours prior to taking them up, these are definitely not the kind of children who you would take them up immediately after birth, although we do see NICU units who push to take them up, but it doesn't help. It just worsens the condition, it worsens the PPHN, and whatever you're going to do intraoperatively is going to worsen their prognosis. So what we do even after shifting them to the OT is we do a baseline echo. So we see, and typically, if the PPHN is a lot, you can see the right side this is the right side, it's completely dilated. It shouldn't be this way. And look at the left side, it's, there's hardly any flow here. Now here you can see that there is a TR jet, this orange colored jet that you're seeing coming up. So this is the tricuspid regurgitant jet. And this is an indicator of pulmonary hypertension. So you can actually measure this jet and find out the severity. And you can see this interventricular septum also here. So it should actually be bowing into this RV like this, and the LV should be nice and full. But here you can see this is a very severe PPHN where it is going into the LV. So this again is you can also look at the tricuspid annular plane systolic excursion over here and see if that is okay for right ventricular dysfunction. So you can see here, this is almost 50 millimeters of mercury. We've quantified it, and this is quite a severe PPHN. So here you would need to start some drugs. So what is the protocol of management now? It's a little different approach that is followed. So first you correct the underlying metabolic abnormalities, you correct the hypothermia, the acidosis. There is going to be some amount of acidosis, so we can accept a pH of up to 7.2 and a PCO2 of up to 60. It will be very difficult to further stabilize them. Look for hypocalcemia, correct all that, hypoglycemia, polycythemia. So we ventilate them conservatively. Now, if your PaO2 is remaining less than 50 and preductal sats are, going less than 88, this is where we start a trial of rescue therapy, or you monitor something called an oxygenation index. And in our center, when the oxygenation index starts going up to more than 6, that's when we start a little bit of milrinone or sildenafil. So now mostly we give milrinone. When it goes above 10, that's when we start the inhaled nitric oxide. So we have an inosis system, and it looks just like an anesthesia, a small anesthesia delivery system with 2 limbs, and accordingly you modulate the levels of nitric oxide given. Some centers give surfactant, so these are hypoplastic lungs. They may not improve with surfactant, but still the idea is whatever lung is formed, you try to recruit that lung, and recruitment really helps to decrease the pulmonary pressures. And finally, when the oxygenation index goes up very high and when there's nothing else that you can do, we go in for ECMO. So a lot of them we start HFOB when the oxygenation index goes above 18 or up to 20. So open versus thoracoscopic repair, in our center, we no longer do the open repair, and unless they are very sick babies, again, for thoracoscopic repair, you need to optimize them. They will not be optimized initially. They need that initial 72 hours or maybe even more. So you can proceed for thoracoscopy if the FiO2 requirement is minimal or less than 50%, if the PIPs are less than 25, if the mean airway pressures are less than 12, and if the PaCO2 is equal to or less than 60, and there is no bidirectional shunting when you search for your TR jet. So some centers also follow this, that if the stomach is in the abdomen, they do an open approach. If the stomach is, but we do not follow that in our center. Most of the babies are taken up for thoracoscopic repair. Now the problem is the surgical repair is again going to add a lot of a lot of stress to this baby. And you can see here, you do not have any access to the patient. This is the position. And all around you, you will have surgeons, and here you will have a big screen. So this is all that you get. Your anesthesia machine will be somewhere here, and there's only place for one anesthetist here, and you have to have all your IV lines and everything over here that you can nicely give your boluses or whatever you need to do. Now we have moved away from an inhalational technique for maintenance of anesthesia, even for induction, because we've noticed that they come with milrinone, and then we have to start adrenaline. They do not tolerate the effects of inhalational anesthetic. So we follow a completely IV approach, and they come with this midazolam and fentanyl infusion. So we just step it up, and sometimes we bolus them as well, and we give a muscle relaxant. So commonly performed here, you can see this is the wax incision. You do not need to isolate the lungs here, and since the lungs are hypoplastic, even the insufflation pressures needed are very less, maximal flow of 1 to 1.5 liters per minute. So here you can see they have put in a mesh, and they have done a complete mesh repair over here when the defect is large. So intraoperatively, they come intubated. If they are not, you can perform a modified RSI. I will tell you how we do that. And now we have also started remifentanil infusions, so that considerably reduces the amount of other agents that we need to give. And like I said, you can go completely off your inhalationals. So regional anesthesia for them, again, we use USG guided erector spinae plane blocks. It helps us to come down on the other anesthetic levels. And there have been reports where very sick babies, they are, either the NICU HFOB has been shifted to OT and all, but I do not have experience of that. We have never done that in our center. So intraoperative challenges are your worsening pulmonary hypertension or a pH crisis. So here you will need your milrinone and all those other agents. If you have sildenafil, we give it through the Ryle's tube. Adequate warming, adequate analgesia. You try to to hyperventilate to reduce your PaCO2. Now in a laparoscopic approach, it's going to be very difficult, and we've seen that PaCO2 levels go up to 80, 90 as well. Now having said that, neonates tolerate very high PaCO2 levels for short periods of time. Maybe for the procedure of thoracoscopy they will, but post-operatively these babies have a lot of problems, and it's actually very difficult unless you have a very good NICU unit. It's difficult to handle these kids. So you may have a contralateral pneumothorax on the other side, and you have to limit your PIPs to less than 25 to avoid this. So I'll move on to the next emergency, which is omphalocele and gastroschisis. So which one is commonly associated with anomalies? It is omphalocele, but both of these are, emergencies, and they're operated immediately after birth. So omphalocele is frequently associated with anomalies, and here again, this is another condition where you need to get an echo done. You have to insist on that because cardiac anomalies are very high. Gastroschisis is associated with mostly bowel anomalies. Now, since the losses are a lot, you have to replace fluids over here at a very high rate. So we usually take central lines for these children, because whenever you give fluids at such high rates, if you're going to more than 50 or ml per kg per hour, you're going to fire the peripheral lines of these neonates. So therefore, from the beginning, we put in a central venous line. A lot of centers have reported doing only regional anesthesia, like they give a spinal block. I would prefer going in for a caudal, like Vineet said. We are not very comfortable with subarachnoid blocks here. But we've also seen that, only giving caudals and only giving very minimal just sedation for them, it doesn't really help, especially when they're depositing the contents. So at that time, it's difficult to monitor pressures also. And that is something, the airway pressures, that is important for you to monitor. So some authors say that keeping the child on spontaneous ventilation is better, because if they lose that, you can make out that the reduction is too tight, and so you ask the surgeons to stop. But if you put in an endotracheal tube, it's advantages, because you can actually measure the peak airway pressures. And if it goes above 25, that's when we tell them that it won't be possible to reduce any further. So then they do something like a silo placement, and they keep this under under pressure, and it slowly deposits itself into the abdomen over a period of time. So if your peak inspiratory pressure is more than anything above 25, you have to be careful. Above 35, definitely you have to say no. If your CO2s are going above 50 EtCO2s, and if your CVP increase is more than 4, so here again is where your central line helps. That is where you ask them to stop and do staged repairs. Now I'll move on to the next one, which is a classic case of IHPS. So here you can see the picture. There is alkalosis, and it's metabolic alkalosis. You can see the bicarb levels are very high, and there is hypokalemia and hypochloremia as well. So this is a typical case of idiopathic hypertrophic pyloric stenosis. Now these, like I said, these babies usually come at around 6 weeks, and they usually male children. So this is the management. Again, it's a medical line of management. This is not a classic neonatal emergency. You can take your time. You can stabilize these children. You have to start them on fluid resuscitation with dextrose, and you can take them off if the bicarbs are come down to at least 26. And if your chlorides go above 100, then you can go ahead with a pyloromyotomy. And usually, again, we do a lap procedure, but you can even do an open repair over here. So these children are prone for aspiration, and a simple thing that you can do is a bedside ultrasound. So of the gastric antrum. So you ensure that the child is in the right lateral position. You should be able to see the liver and usually the descending thoracic aorta here. So you can see there is some amount of fluid here, and then you aspirate that in all quadrants, and then you move ahead with something called a modified rapid sequence induction. So I've just made a small video. So at the end of the procedure, you need to inject air via the nasogastric tube to ensure the pyloric patency. That's one step that we are involved in. And again, analgesia over here, if they're doing a laparoscopic repair, you can give a tap block. And if they're doing an open repair, you can you can go ahead with your cord loop. So what about the neonatal NORAs for CT and MRI? So we follow the feed and wrap or the swaddle technique in our institute, where most of our neonatal, in fact, up to 6 months of age, we do it by this technique, and it's very safe. Even you can use this in peripheries also. So the baby is, you ask the mother to keep the child starving, preferably at least for 4 hours. Then when she comes to you, the child should be sleep deprived. You ask them to keep the child awake, do anything to keep the child awake. Now you ask the mother to feed the child just before initiating imaging. So now the child feeds, and using that feeding technique, the child sleeps. So it's a natural sleep. You can just put in a pacifier to keep, dipped in sucrose, and you dim the lights, and you can put earmuffs. So this is a swaddle bag which is available, and it gives very good success rates in infants up to 6 months. Now, this is what Dr. Gayatri from our department did. So she made an immobilizing device, and you can do it, it's very simple. You get these things, and she's just attached Velcro and nicely snuggled them, and they sleep very nicely. Now, what about lung isolation? So these are just a few of the recent advances. Lung isolation is not really required in neonates. It's difficult to perform, but this is one where we did it in a CLE, and we used a Fogarty, a 3 French Fogarty here. So usually you can do an endobronchial intubation. Again, that is not a very popular method, but you can use a Fogarty catheter here. And we had to you have to do a bronchoscopy there to get the cuff out on to the proper level, or to check whether you've gone in the correct right or left mainstem bronchus. So again, remifentanil that we've started using for for neonates now, and we start at 2. So we have a TCI pump. You can also use the infusion method, and we've started using rocuronium for intubation and reversing them with Sugamadex. So this was like not even 15 seconds after Sugamadex 2 milligrams per kg was injected. You can see the neonate is nicely out and ready, all set for extubation. So remifentanil, you can take a screenshot of this. These are the doses, and we usually start with 2. So this is the TCI pump that we use, and we target the effect site. Actually, we use the Eliveld model. So here we start at 2 nanograms per ml. So it comes as a 1 milligram, a small vial, and you dilute it with 1 ml. You reconstitute it with 1 ml of normal saline, and then you put it in a 50 ml syringe with normal saline. So you will get around 20 mics per ml over there. And then you feed that into the TCI pump, and then it just calculates everything based on the weight, the height, the age of the child. And the planes for surgical anesthesia and for pain stimuli, you can go up to 6. We usually don't go beyond 6, and beyond 10 nanograms per ml, you can get chest rigidity and other problems. Now, this was post extubation, so then we set it to 0. This is what you set. The target concentration, and this is what is actually, so the at around 1.34, when plasma levels go up to this, that is when you can safely extubate these, and we monitored this child here with NIRS. So you can see, some amount of shivering does happen with remifentanil. It's there even in neonates. You can see the shivering for some time. But other than that, we've never seen any other side effects, not seen bradycardia or any such thing, or chest rigidity also we haven't seen with the doses that we use. So again, thank you to all of you all and for your patient listening the fag end of the day, and I hope I made some sense at this time. Thank you.
Excellent, madam.
Thank you.
Excellent.
Hello, over to
All
chairperson.
presentation were
Yes.
excellent. Thank you very much.
I think all 4 topics were very well covered, and this is the era of elegant precision, and all of them have shown the precision in every aspect of pediatric anesthesia. I must congratulate all of them. Thank you.
Due to time constraint, we are not answering the delegate question. That's the only problem today happened due to time constraint. Thank you very much. Pradnya ma'am,
Over to Pradnya ma'am.
you have remarks? Any remarks? Pradnya Sawant madam, are you there?
Yes, of course, yes. So
Yeah.
I think no question answer, no question answers. So I think all really Priyanka, Vinit, they have done really very well, because
Ask you on phone and then circulate in the groups the question answers.
Yes. You can put them in questions in I think on the WhatsApp group, and they can definitely will be able to answer. Well, I think
Yes.
Raylene has done a good justice to, because this topic is quite vast, and we had discussed that not each and every emergency to be discussed, just main emergencies to be discussed. I think neonate you want to do that is actually today's title is appropriate for neonates only. There are not many others. So once neonate comes, it is a different ball game. So you should know ABC and PP. ABC means that is the basic things that Raylene has said, and PP means pain management and these things of pre-medications, if at all it is required. Pain and pre-medications. Post-operative pain management is also sometimes missed in the neonates. That's quite important. Poonam has also done well. I think all of them, they have done really very good. I'm very sad that we don't have question answer session, but they can definitely take over. Excellent.
Yes, madam, it's almost 9:30. So I request Dr. Sheetal to present out of thanks.
Thank you, sir.
Before, yes, thank you.
Thank you, sir. It's
Please.
my honor to propose the customary vote of thanks on this occasion of pediatric anesthesiologist webinar. So, I extend my sincere gratitude towards both the chairperson, Dr. Snehalata Thaigude Madam and Dr. Pradnya Sawant Madam, for accepting our invitation as a chairperson and sharing the vast knowledge of pediatric anesthesiology, and also giving the valuable inputs and clearing the doubts of the delegates today. My sincere thanks to all the faculty. It's very crispy, the lecture full of practical tips, what we called in Sanskrit. It is full of Vidyanam, Kaushalyam and Bhava. That we are to give anesthesia to we should have knowledge, skill and even attitude while dealing with these pediatric patients. My sincere gratitude towards our MMC observer, Dr. Sanjay Kaplani. He is my batchmate too. Then I thanks to all SAM members for the huge response. Today we crossed the double century going toward the triple century also. So thank you very much. Long live ISA,
Credit
long
to you
live
also.
SAMs.